Hello, Wealth Masters. My name is Greg Phelps, and I am your host to the Wealth Summit. Our mission here at the Summit is simple. We want to educate and empower you with actionable tools, tips, and tactics to help you grow, protect, and maximize your wealth. And I can't think of any better topic today to be discussing than managing healthcare costs and retirement. We've got a very special guest, David Arms. David, are you ready to help us master our wealth?
I am ready. Put me in, Coach.
All right, we're going to put you right in. So a little bit about David. David is the president of Dover Healthcare Planning, LLC. He's a certified financial planner with 10 years of experience in Medicare counseling. He's been quoted in articles about retirement healthcare costs in the New York Times, the Dow Jones Financial Advisor, Bloomberg, Businessweek Online, and Financial Planning Magazine. He's also written articles about Medicare and related health insurance topics for several financial publications, including Financial Advisor Magazine and the Journal of Financial Planning. David, you've got quite the reputation there, so why don't you go ahead and take a second and fill in any blanks that I might have missed in your quick bio.
Sure, Greg. First, I appreciate the opportunity to be here. I retired several years ago from a corporate job looking for something to do. At the time, I decided to become a volunteer Medicare counselor for the County of Los Angeles. I did that for 4 years, really came to understand Medicare fairly well. It's a very complicated area, of course, but I understood much of it, and what I saw was that the people I counseled frequently were not thinking in financial terms. They were trying to get their enrollment and eligibility questions right, which is important. They were not really looking at the longer term implications of various types of coverage. If I choose this type of coverage, what's my cost likely going to be in 5 or 10 years? And so at that time, I decided to start my little business. We've been in business for a decade. And, we're trying to help people just manage their costs, understand their options. We don't sell insurance, recommend insurance. We just explain the process to them.
Right. Well, I personally have knowledge of your expertise because I actually, Wealth Masters out there, a little note, I do send my clients to David for the Medicare reviews and so forth. He's done an excellent job over the years. So thank you so much for that.
Thank you.
So let's go ahead and set a foundation, Wealth Masters, and just kind of talk about the basics to get us all on the same page. And the very first topic on that is that healthcare costs are actually different than other expenses. So David, why don't you go ahead and kind of elaborate on that?
Sure. And I think most people know this intuitively, if not maybe academically. One is healthcare costs tend to increase at a faster rate than other costs. Healthcare inflation is faster over the last 30 years, according to the government CPI index. Healthcare inflation has grown about 1.5% more each year on average than other kinds of spending. So as people look at healthcare costs in retirement, they need to be aware that their costs for healthcare are likely going to increase at a more rapid rate than their housing costs, their food costs, and other costs. Also, healthcare is more complex. There are just a lot of options. Medicare, as I mentioned a moment ago, can be complicated. Parts of it are simple, parts of it involve a lot of detail. And people aren't sure how to manage that. They say, I don't understand it, I get confused. So that's different than housing costs, which are a large category of retirement spending. People know how to manage their housing costs. They've been doing it their whole lives. They can, many retirees downsize almost 40% their homes. Some take out reverse mortgages. They know the tactics they can use to manage those. When it comes to healthcare costs, not so sure. I don't understand this. It's confusing. What are all these, deductibles, copayments, cost sharings, secondary deductibles that apply to certain services? So they just give up and stay in the same plan. Costs are unpredictable in healthcare. They're based on your health, basically. I had a client last year during open enrollment who really had monitored her costs carefully. She was in her early 70s at the time, and her costs were pretty much on track. She knew it could be a big liability, so she was trying to stay on top of it. Her doctor at that moment had just prescribed a new brand name drug for her, which she needed to take. She was not seriously ill, but he said, I think this brand name drug will help your overall health and maybe prevent future complications. She started taking it. At the time she started taking it, Greg, her healthcare costs were about $3,400 a year, we estimated. That included her Part B premiums, plan premiums, copayments, for the drug she already took. This one drug, not an expensive drug as brand name drugs go, raised her cost by $1,500 to roughly $5,000 overnight in 1 year. That those costs went up more than 40%. So healthcare costs are unpredictable, particularly drug costs, because the coverage, even the Part D coverage for those is not, it's good, but it's not great. So there's an unpredictability about what kind of medical services you're going to need. Many people need medical services that are not covered by Medicare. And then partly because of the health inflation rate being higher, you tend to find that healthcare costs tend to be greatest in the last half of retirement, particularly the later years. And so there's a shift in costs, as we'll see, I think, on a future slide. There's a shifting of costs to later retirement, and that's where many people are surprised. They get to later retirement and they say, wow, I had no idea.
Yeah, well, let's go ahead and talk right now about that shifting costs towards late in life medical expenses.
This is from a New York Times summary of research that appeared earlier this year. This is spending per person. We all know that healthcare costs and premiums go up as we get older. 30-year-olds pay more in premiums than 20-year-olds. That trend continues throughout and actually starts to accelerate slightly in later retirement. This just shows the total spending per person. This is not out-of-pocket spending. This is what the system spends, including out-of-pocket spending. But as you can see, once you get to 75 and older, your expenses are twice or 4 times as much as they were before you turn 65. They're 6 times as much once you reach age 85. So that you see this shifting of costs, primarily because people, first of all, healthcare inflation, but also people are using more medical services. They're taking more drugs as they age. They're more likely to take brand name drugs. They're more likely to use services that are not covered by Medicare, certain forms of in-home care and things like that. So there's this, I mean, it's one of the key elements in planning for healthcare costs is the realization and preparation for this later phase of retirement.
Right, and as you mentioned, I mean, the expenses are just going to ramp up exponentially as you're showing here on this chart, and it's just something that has to be taken into consideration. I know when we do plans for clients, we assume anywhere from 6 to 6.5% inflation on just the medical costs.
Yeah, and that's it's a little tricky because you can look at out-of-pocket costs. Typically, people's out-of-pocket costs don't go quite as quickly as healthcare inflation because the insurance company, and in Medicare's case, the government, absorbs some of that additional inflation. But they still go up faster than other kinds of inflation. So
okay. So let's kind of transition to looking at out-of-pocket spending at different ages as well. This is a very similar slide.
Yeah, this is the prior slide showed just total spending by the system. This is what people spend out of their pocket in premiums, co-payments, deductibles, cost sharing. And it's approximately 2 times as much at age 85 as at 65. Now, this chart, as simple as it looks, can be misunderstood. Some people will see this and perhaps think, okay, what this means is I'm 65 today, and when I'm 85 in 20 years, I'm going to spend 2 times as much. That's really not what this chart is saying. This chart is saying that this year, 2017, the average 85-year-old is going to spend twice as much out of pocket as the average 65-year-old. And that's because of higher premiums in individual policies and also greater use of medical services.
Okay, and that kind of makes the medical spending pattern look like this chart here, where we've got this rapid rise towards the end, later in life.
Yeah, and there have been so many studies that document this shifting, this backloading of healthcare costs. And a typical pattern, and again, there's a lot of variation among individuals, is that 2/3 of your retirement healthcare spending will come after in the second half of your retirement. And again, there's variation. That's not a prediction that's going to apply to everybody, but people need to be aware as they think about this large expense for retirement that it's going to get bigger in all likelihood and can, in some cases, overwhelm them in late retirement.
Right, and I suspect, and you can elaborate on this, I'm sure, but the fact that we're living longer really back
Yeah.
end loads this whole expense thing.
Yes. Yeah, a big factor is longevity in these costs. And we'll see in a moment, I think, some projections or estimates of costs. And those are the primary determinant is going to be longevity. In many cases, the average Medicare beneficiary pays 70% of their costs in premiums. So even if you never go to the doctor, you're going to be paying those premiums every year. And so if you live 5 years longer and never go to the doctor, let's say, during those 5 years, your premiums are going to be going up 5% a year, perhaps 4-5%. And you're saying, but I'm healthy, but you're also living longer, and so your total expenses are going to be increasing.
That's a perfect segue. So I know there's a lot of studies on exactly what we can expect to spend in retirement on healthcare, and I know the numbers are pretty big, right?
Numbers are very big, and I wouldn't put credibility. I tell clients, and when I write about this, none of these is a prediction. These are estimates. All of these estimates on this page are made by organizations that have been doing healthcare cost estimating for Medicare for, in one case, 20 years. Society of Actuaries have been doing it for like 35 years. These are estimates of how much a 65-year-old married couple will spend if they do not have employer coverage. If they have employer coverage, it will vary depending on how good that coverage is. Will probably be a little less for most employer plans because the employer is subsidizing that coverage. But 2/3 of people retiring do not have employer coverage. You can see here in the right two columns the life expectancies that are assumed for these projections. So this, again, none of these, it's not like this one is going to be right. We don't know which is going to be right. They're probably all going to be off a little. There's a benefit to looking at these, I think, though, just to give people an idea of the potential magnitude of their costs. And that may do a couple of things, Greg. It may encourage them to monitor their coverage as they go throughout retirement. Like, I know later my expenses could get very large, so I need to pay attention to this. This is a large expense. And the other thing is, in some cases, it will shift them to a different kind of coverage in early retirement. Many times, and this is one of the mistakes I saw people make when I was a Medicare volunteer counselor, they will jump into the most comprehensive plan they can get, which is also the most expensive plan. They're 65 years old. They're still, most of them, in very good health. They don't go to the doctor much. They do not need comprehensive insurance. They may need that comprehensive insurance in 20 years, but they're wasting, in some sense, their dollars if they spend it now. Now, if they're very affluent and it's not an issue, then that's fine. I mean, they'll enjoy that very comprehensive coverage. But the costs, to go back to this chart, the costs, while unknown, are substantial. And if you look at the life expectancies here, I mean, in many cases, people are going to live longer than these life expectancies.
Right. And these numbers are fairly shocking. I know when we discuss them with people and you say, hey, by the way, you're young in retirement, you're early 60s, mid 60s, you're looking at $300,000-$400,000 that you're going to spend over the rest of your life for medical services and healthcare.
Yeah. And I think that's a good ballpark for a couple. For a married couple, is approaching retirement, I would say, 300,000. In fact, I think the next slide we'll see talks a little bit in terms of what you should have set aside theoretically at the start of retirement.
Yeah, let's go ahead and tackle that one right now. So if I wanted to pay for all of my healthcare expenses up front, how much money do I need?
Well, let me just preface this, Greg, by saying this is from the Employee Benefits Research Institute. Most of these, the first one's not. This is money. These are what financial planners call present value dollars. This is how much, as you said, you need today to have in the bank. So I'll jump down to Employee Benefits Research Institute just to take one example. They're saying that a 65-year-old couple who doesn't have employer coverage, if they want to have a 50% chance of having enough money to pay for their retirement health care, should have about $165,000 in the bank. Now, they're assuming that's going to earn that in their modeling. This is a Monte Carlo analysis, as it's called. They're assuming that investment's going to earn an after-tax rate of 7%, which is optimistic.
That is optimistic. Yeah.
So, but they again, and they probably do the best job in terms of looking at different situations. They look at what happens if you have average drug expenses or median drug expenditures. What if you're in the 90 percentile range? And in the 90 percentile range, you can spend twice as much for healthcare if late in life you need some expensive drugs.
Right. Wow. So $165,000 in my investment account right now that grows at that 7% number. That'll cover, my medical expenses throughout retirement with a 50% possibility. There's also 50% that I'm going to run out of money.
Exactly. Now, I guess the one thing that I would just say here, and it's an optimistic note, is all of these projections use a Medigap policy because it is the most predictable expense in their modeling. It's very hard to model Advantage plan costs far out. And Medigap policies, as I think we'll talk about, typically are the most expensive choice. So they are assuming very good coverage here. And I think many people, as we were saying earlier, don't need that comprehensive coverage when they start. But these are numbers. The Employee Benefits Research Institute has been doing this for 25 years. They testify before Congress on these numbers when Medicare legislation's up, so they know what they're doing.
Yeah, EBRI is very good. I've seen a lot of their reports and their analysis. So let's kind of transition a little bit, David, and let's kind of jump into how do we control some of these costs?
Okay. There are really three key things. The first is to avoid late enrollment penalties. That's a one-time deal. When you first enroll in Medicare, whether at age 65 or some people continue working or their spouse continues working and they enroll later, there are some very simple but strictly enforced rules. And there are about 750,000 people today that are paying lifetime late enrollment penalties because they didn't understand those rules or thought they could get away with ignoring them. Social Security handles the initial Medicare eligibility and enrollment process, but it's important for people first to get through this first hurdle, which is to make sure they enroll on time.
And David, what are the rules on that?
Well, they're complex, Greg, depending on a lot of things. When they retire, there are different rules for people who retire at 65 or older than 65, or disabled people who apply younger than 65. They're slightly different rules, but basically, let's take somebody at 65. You have a 7-month period that begins 3 months before the month you turn 65. During that period, you have to make your choice. If you don't make it, particularly for Part B, if you don't enroll in Part B or have Part D coverage by the end of that period, you're at risk at least for facing a lifetime enrollment penalty. The rules for Part B is if you go a year without it, you're going to pay 10% a year for the rest of your life on premiums, and those premiums go up. With Part D, it's 1% a month for every month late, but you're locked out of enrolling. Once you pass that initial enrollment period, you can't get back in. You can't do it the next month and say, oh, I missed it by a month. You're locked out until the next general enrollment period in that case.
That seems like a pretty critical upfront move that you've got to get right.
Yeah, and most people do. I mean, 1.5% of all 59 million Medicare beneficiaries don't get this right, but it's an important element, and it's fairly easy to handle if you're paying attention. The second thing is to make that initial choice of your supplemental coverage. Give it some thought. Think about how much it's going to cost in the future. It's hard to predict because of the unpredictability of healthcare costs, but you can still do some ballparking. And as I said earlier, Medigap policies can be very expensive. And we always caution all of our clients, saying just be aware. If you want a Medigap policy from day one, there are some things you can do to save money, but this is still going to be the most expensive type of insurance. It's a great insurance, but you're going to pay $100,000 in premiums by the time you reach age 90 if you use the typical comprehensive plan.
And David, real quick, just to refresh on the Medigap policy, that's going to cover what Medicare doesn't?
Yes.
Okay.
Yeah,
just want to make sure I have that clear.
Yeah, and I'm sorry for jumping into terminology here.
No, you're fine.
Well, we have a chart coming up that'll explain the different kinds of supplemental coverage. The only point I was really trying to cover is that Medigap policies are very expensive, and that people should be aware when they first enroll in Medicare. They should give some thought. They should understand what those costs may be. And then if they can afford it, or maybe if they were having health problems already at age 65, they say, I want this really good coverage.
Right.
Other people may not. The third bullet on here is just to review your coverage yearly. Medicare, like most employer plans, has an annual enrollment period, October 15th through December 7th. Plans change dramatically from one year to the next. So people who do not do this are at risk, and we may talk a little about that later, but if we have time. But coverage changes very quickly, particularly prescription drug coverage, and you can be in the lowest cost plan this year for the drugs you're taking, and next year it can be several $100s too expensive, even though you're taking the same drugs.
Wow. Okay. So it is pretty critical that you not only get into the right plan, but you constantly review and update where your health is, what your finances are with, and match that with the actual supplemental coverages and your Medicare plan, I guess.
Yeah, that's well said. That's exactly it. The dilemma, unfortunately, is that as people grow older and their healthcare costs are increasing, they are less likely to do this. Some of them just don't have the intellectual capability that they had when they were younger to go in and review their coverage. They don't know where to go to get somebody else to review it. So you see among the older population, Medicare statistics point this out, less and less frequency of changing plans or reviewing coverage. So at the same time the financial stakes are highest, people are least likely to be monitoring their coverage.
I don't know this for a fact, David, but I would guess, just anecdotally, having worked with people over the last couple of decades, I would guess that 90% plus don't ever bother to review it.
Yeah, and that's a good number because there are a number of studies. We don't know how many, there's no way to know how many people, there's no precise way to know how many people don't review it, but you can tell real precisely how many people change plans. And you can also tell very precisely with drug costs how many are in the wrong plans. And 90%, some studies say, never change plans, and like 90% of that 90% are paying several $100s a year too much. So there's a high percentage of people that never change plans.
Right. Right. So it is important, though, because as you mentioned, several $100s a year should be money that you're enjoying on your trip and your retirement and spending time with the grandkids. It shouldn't be wasted on unnecessary medical costs that you really don't need.
Yeah, and 1 year is bad enough, but what we sometimes see are people that just, you're talking about year after year after year, drug costs go up, they're not reviewing the plans. And we get several clients every October who come in and say, my drug costs are killing me. These are typically people in their late 70s, early 80s. Not always, sometimes they're younger people. But they're saying, help, is there something I can do here? We just do a very simple, we do a simple search and say, here's the lowest cost plan for the drugs you're now taking. Next year, you can switch if you want, call this toll-free number. And your prescriptions will probably be transferred over to the new plan. If people did that much, and they can do that by calling 800 Medicare at no cost, Medicare will do that for them. But people don't do this, and over the course of retirement, I've seen people that I'm convinced have left tens of thousands of dollars on the table because they're taking expensive drugs and they never monitor it, and they just, they look at their bill and they say, wow, well, I guess all these articles about drug costs being high are right, but they don't do anything to see if they can control it. Some cases they can't, there's nothing, but in many cases there is.
So I love the word that you just used, control, because I always say at the end, and I'll say it again in a few minutes here, either you control your money or it will control you. And this is just a perfect example of something that you can do if you put in some time, some effort, some thought, hire a qualified Medicare advisor, somebody like David, that you can actually reduce your cost over your lifetime. And that's tens of thousands of dollars that you just mentioned that you potentially could have given to your kids or grandkids.
Yeah, very true. Very true.
Yeah. So David, let's kind of transition and talk about some of the supplemental coverages that are available.
Okay. Greg, we touched on this a moment ago when we talked about Medicare policies. This is where many people get confused. What are all the different kinds of supplemental coverage? There are 4 types of supplemental Medicare is called primary coverage. It's going to pay first. And it has a lot of gaps, as people know. There are 4 different ways to supplement those gaps or to cover them. I've only listed 3 here. The 4th is Medicaid. And I've assumed that most people who listen to this are not going to be using Medicaid. Medicaid's rules also vary a little bit by state. The first of these, which we discussed, is a Medigap policy. And that's basically called a traditional Medicare supplement. Medicare pays 80% of the bill. The Medigap policy pays the 20% balance. These are very nice policies, as we said. They tend to be expensive. They do not include drug coverage. So people who choose a Medigap policy will also need to enroll in a standalone drug plan. They're called Part D standalone plans. They choose those plans not based on premiums, but on the lowest cost for their drugs. And unless they don't take any drugs, frequently a low premium plan will not be the lowest cost plan once you take into account the deductible and the copays. And many seniors, many retirees just say, I don't understand all this stuff. I'm going to choose a low premium plan, but that may not be a good solution.
Okay.
The second type of coverage is a managed care plan. These are much less expensive. They involve more risk, more out-of-pocket risk if someone got seriously ill. But many of these plans, maybe half of those in the country, are zero premium plans, meaning you have no premium at all for either prescription drug or medical coverage.
Wow.
The out-of-pocket risk is fairly high. It can be several, $4, $5, $6, even in some cases $6,700.
And that's the Advantage plan that's on your chart here, right?
Yeah, these are Medicare. They're called Medicare Advantage plans, Greg, and they are managed care plans basically. Most of them, 60% of them, are HMOs.
Oh, okay.
Another 30% are PPOs. And then there are a few, depending on the state, there are a few other smaller private fee-for-service plans and cost-sharing plans.
But and you mentioned there was no premium. How do they afford to send out the money for all these claims?
Yeah. Once you join an Advantage plan, Medicare pays that plan every month. Let's say $1,000, and that it's going to vary by person, by their age, by their health status. But Medicare says, okay, we're no longer taking care of this person. They have decided to enroll in an Advantage plan. We're going to pay that Advantage plan a set fee based on those factors that I mentioned. And it varies depending also on part of the country you're in and what the medical costs are. But I'll just use $1,000. So they'll pay a plan $12,000 a year for an enrollee. If that person doesn't go to the doctor much that year, the plan's going to make a lot of money.
Right.
If that person goes in the hospital and skilled nursing facilities for long periods of time, they may lose money on that particular patient. But overall, they come out ahead. They make a slight profit on average, and they get their money from the government, so they can afford to entice you with a zero premium plan. And about
it's almost like catastrophic coverage or something.
Well, it's pretty good coverage. There is an out-of-pocket limit in it. It varies a great deal by plan. In urban areas, we see a lot of this in Southern California. There are some exceptional plans: zero premium, zero deductibles, zero cost sharing, zero co-payments for doctor's office visits, specialist office. If you get out into rural areas or less urban areas where they have a lower population base, you'll find that they tend to be weaker, and that their networks are smaller. It's less likely you're going to find your doctor in a plan. So they're really good in urban areas. They can be good in remote areas, rural areas, but rural areas are people primarily that are doing Medigap or buying. That's where the Medigap concentration is most.
Okay.
And then the third kind are employer plans, and those come in all shapes and sizes, depending on your employer. I have an employer plan. I retired from a large company. Someone will get that phone. I apologize.
No, it's fine.
And there's a lot of variation here, depending on the plan. These are usually the best options for people who have them. Typically, These are going to be offered by very large companies, Fortune 500 companies, government agencies, some cases school districts, federal employees unions, but they're subsidized. And they're also group plans, which gives them some pricing advantages. And most of these plans include drug coverage. So these are the three options. Really, if somebody has the employer plan, that's in 90% of the cases going to be their best case.
That's the best one.
That if they have that option, about a third of people do. If they don't, the other 2/3 of people will have to choose between a Medigap policy and an Advantage plan. And that's where we try to evaluate the costs and risks of each of those. One thing we do on the Medigap policies, we continue to say they're expensive, but there are different Medigap plans. So we frequently advise people to at least consider a less expensive Medigap plan that is still pretty comprehensive. Most people, insurance agents like to sell the most comprehensive plans because they get the most commissions.
Right.
And 2/3 of the people in Medigap policies have a plan with zero deductible, and it just, I mean, I could go on and on. It's crazy how people overpay. They pay more in premiums than they save in the deductible if they compare it to a plan that's the same coverage but does not cover the deductible. So, and we've seen people pay $700 or $800 a year too much just when they could change one plan and do the whole thing a lot cheaper and better coverage, really. So those are the options. People can choose among those. The fourth is Medicaid. 17% of people in Medicare are also on Medicaid. Medicaid supplements Medicare. Medicare still pays first in all of these scenarios.
Okay. And David, as we kind of wrap up and bring this home real quickly, can we just hit the four parts, A, B, C, D, and just a real quick overview of those for the viewers?
Yeah. And this is confusing to many people. Part A is basically hospital insurance and services related. It does not have a premium if you've worked your 40 units, and 99% of people who have Part A pay zero premium. You should enroll at that at 65, even if you continue working. The exception is if you have a health savings account at work, enrolling in Part A will disqualify you for that health savings account. Part B supplements the outpatient services, doctor services primarily, and that's typically, and there's some variation here, but typically Medicare is going to pay 80% of a doctor's bill. The supplemental insurance would pay the remaining 20% or some portion thereof, depending on the type of insurance. Advantage plans, as we said, are maybe we didn't say, that's Part C. And so if you enroll in Part C, it includes your drug coverage in most cases. It always includes your medical coverage. So that's called Part C. People say, I want to enroll in Part C. They mean they're enrolling in an Advantage plan. And then Part D is, of course, drug coverage. It was added in 2006. Many kinds of coverage include the drug coverage with them. We said that Advantage plans usually do, not all of them. Employer plans usually include creditable prescription drug coverage. Medigap policies do not. You have to have drug coverage that Medicare says is good enough to avoid a penalty. And so all of the plans here will certify that Medicare has said their plans are good enough to avoid a late enrollment penalty.
Okay. And I guess two more questions. One would be, how many different types of Advantage plans or Medigap policies out there would I have to choose from? How broad is this market?
It again is going to vary a little bit depending on whether you're in an urban area or not, but I'll just use Los Angeles County where I am. There are 10 Medigap plans to choose from here. We narrow that down to 2 or 3 that we think are good options. There are 30 insurance companies. They all have different premiums. Premiums can vary by 50% for the same plan, same benefits. It's amazing. So you not only have to choose the right plan that's going to meet your needs, then you have to find the low premium, one of the lower premiums, or you can choose an Advantage plan. In Los Angeles County right now, I think there are 32 Advantage plans. All of them are HMOs. So your only choice here, if you want in Los Angeles County, is if you want to enroll in an Advantage plan, and you'll get a lot of zero premium plans here, would be an Advantage plan.
Okay. And final question before we wrap up. I like to give the wealth masters out there some specific actionable things or key takeaways. And so just envision for a moment that you're talking to your brother and he's turning 65 and he needs to figure this out. What are the most important things that he needs to know, both in selecting that initial coverage and planning for the future?
Okay. Well, I would say first, be sure you get the enrollment right. If you get that right, it's a one-time deal. Social Security will help you with that. If you work for a company or are retired from a company, they should help you if it's a fairly sizable company. Get through that right. There are a lot of Medicare counseling agencies out there that will help you through that at no cost. Get that right. Then give some thought, a lot of thought actually, to your initial coverage choices when you first get in. And try to make sure you're choosing the best plan that meets your needs. That makes it less likely you're going to need to change plans in the future if you do your homework up front. And the third point, as we discussed, is to monitor the coverage each year. It's going to depend on the type of coverage you have, what you monitor, but you can learn what you look for. Drug costs are always, for people who take prescription drugs, even one brand name drug, that's almost always going to be your most volatile type of coverage from one year to the next, just because, for a lot of industry reasons. And so we tell people who take drugs, look at this every year. And there are free resources out there. I mentioned 800 Medicare Rights Center. We do it for a fee, but there are people who stay on top of their costs, particularly if they take any expensive drugs, will save a lot of money by doing that.
So, David, you mentioned we do it for a fee. I have two follow-up final questions on that. And one of them is, do you work with clients just in LA County, or do you work virtually with people all over the country?
We work anywhere in the United States. Medicare, of course, is national, and probably 60% of our clients are on the East Coast. So Medicare itself is standardized throughout all 50 states. The types of supplemental coverage and Medigap pricing and rules will vary from state to state, but we understand those because we've worked with them a lot. And then the second question was what? Did you?
I believe virtually. I think I was kind of alluding to the fact that just like we're doing this conversation through GoToMeeting, you can work virtually with anybody. Oh, yeah, I'm sorry. That was it? Yeah.
Yeah, no, that we work with anybody, and our service is really, we do not recommend anything. We just look for plans that we think meet the client's needs. These will allow him or her to continue seeing their current doctors. They fill out a questionnaire, list their doctors and drugs and other things they want us to be aware of. We say, okay, these plans tend to be the ones that seem to fit your needs. This is the most expensive. It has almost no risk. This is the least expensive. If you're in good health, you're probably going to save money there, but it has more risk. And then we never know, Greg, I won't say never, rarely know what they choose. We give them the numbers to call to enroll in those plans, the deadlines for enrolling, to start their coverage on time. So it's really a fee-only service where we just say, here's an evaluation, take it, use it. If you have follow-up questions, let us know.
Okay, and David, I apologize because I do remember what that second question was. It wasn't the virtual. You did address that. I'm just curious. So if I'm watching this interview and I say, hey, I really need somebody to look at this, I want to call David. What, roughly speaking, you don't have to get into too specifics because I know everybody's unique, but what roughly is the fee for doing that?
We just have we only do three types of evaluations. For someone who's enrolling in Medicare the first time, we charge $125 for an evaluation. We send them an electronic file with the comparisons I mentioned. For people who just say, I want to look at my drug coverage every year, we will charge, and they just may want to do it 1 year, we charge $50 for drug coverage. We look at some things Medicare probably doesn't look at, like is there a preferred pharmacy where you can save money? Can you save money with mail order versus retail? We try to really understand the least cost option for them and then see if there are benefits. We charge $50 for that, as I said. If somebody wants us to employ, occasionally somebody will say, I have an employer plan and I'm not sure if it's any good. And I would like for you to compare my employer plan to your Medicare options in my area, to the Medicare options. We charge $200 for that because it takes us a lot more time. We have to come up to speed on the employer plan, what they've got, understand its rules, and raise questions if there are questions to be raised. So we charge more for those. Those are flat fees. They've been in place for a couple of years now. We are going to raise them sometime next year in 2018. I don't know when. Right?
So get your review done now.
Well,
give them a call.
If you need it now.
No, I kind of had a rough idea what your fees were because we have worked together in the past, and my assessment is that for a very small barrier to entry, so to speak, where all the person has to do really is fill out kind of a quick questionnaire, pay that $125 or $50 or in that range, and then they get a professional analysis from an expert that could possibly save them hundreds or even thousands of dollars a year.
Yeah, we like to think we can save people money, but we don't guide them toward a plan, as I keep saying. We just say, here it is, be aware of this with this type of coverage, here are the risks. Here's a different type of coverage. Its strong points and risks are this.
I think there's an incredible value there, and that's why we've been working together for a few years. So, David, if I'm home on the couch watching this interview on my iPad and I want to reach out to you directly, why don't you go ahead and share with us what's the best way to reach out to you?
I think the best way is the website that you just showed, our website. It's doverhealthcareplanning.com, one word, doverhealthcareplanning.com. You can go to our services. There's a tab on that page where it says our services. You can download a questionnaire there. There's an email link. You can send us an email with a question. There's a phone number. You can call us with a question. So there are different ways to contact us, but that site should explain or answer at least the basic questions about what we do.
Dover Healthcare Planning. doverhealthcareplanning.com.
Right.
Excellent. David, thank you so much for your time today. I really, really appreciate it.
I enjoyed it.
It's a topic that I don't know much about, and I'm still learning, and that's why we've been working together, because if I can't be an expert in it, I want to send my clients to the expert, and that's you.
Yeah. Thank you.
So thank you so much. Wealth Masters, either you control your money or it will control you. Again, we already hit on that word control, and you can control your healthcare costs and expenses just by taking a few simple steps, putting in a little bit of time, a little bit of effort. David, thank you so much for your time today.
You're very welcome. I enjoyed it.
This is Greg Phelps for the Wealth Summit, signing off.